Welcome to Working with Special Populations. This particular lesson is about working with women. My name is Desiree Cochran Norfolk. I am an addiction counselor. I have a master's in addiction counseling, and I'm a certified clinical supervisor, certified master addiction counselor, and a CAC2 with the Georgia Addiction Counselors Association. I'm also certified by NAADAC, the National Addiction Counselors Association, as a substance abuse professional, and I'm also certified to do anger management and family violence intervention. So in this session, we're going to explore the unique challenges and needs that women face when it comes to substance use and treatment. Women experience addiction differently than men due to a range of biological, psychological, and social factors. So understanding these distinctions is going to be essential for providing gender-responsive treatment. So by the end of this session, you're going to be able to identify these specific challenges and understand some barriers that women face when accessing services. We are also going to understand how to apply effective relapse prevention strategies that are tailored for our female clients. It's also important for you to recognize that women in treatment are often navigating complex roles and different pressures. A lot of them are mothers or caregivers. Some of them are survivors of trauma, and they may be dealing with stigma on multiple different levels. So this session is going to equip you to approach treatment with compassion and context and some evidence-based strategies that consider these dynamics. So let's jump into this. Women are considered a special population in addiction treatment because their pathways into substance use and their pathways into recovery are going to be shaped by gender-specific experiences. So the research confirms that women are going to face different stressors and different pressures and different consequences from their substance use from that of their counterparts of men. So they're more likely to internalize trauma, and they're more likely to experience co-occurring mental health conditions like anxiety and depression. And they're also more likely to face judgment around motherhood and caregiving. So in treatment, these factors have to be accounted for. Gender responsive care isn't just about recognizing that men and women are different. It's about tailoring approaches so that women feel safe and respected and empowered to engage fully in recovery. Though we are not in an in-person environment to do this exercise, you can find someone of the same sex to do this exercise with, or you can pull up ChatGPT and ask ChatGPT to pretend to be someone of the same sex and to do this particular exercise with. This is to help you start thinking critically about gender and how it plays out in treatment. So by partnering up and listing gender-specific characteristics of men and women, we as counselors are going to be able to start to identify the unconscious assumptions that we are bringing into our sessions. These insights are going to also reveal how different societal norms and expectations are going to influence our treatment engagement, different relapse triggers, and different recovery plans. So it's helpful for you to complete this. I want you to take one sheet of paper and make 2 columns on the paper, label one men and the other women, and in partnership with the other person, write down gender-specific characteristics of both women and men in those separate columns. And we want to kind of talk about how these differences in men and women might affect treatment and relapse prevention approaches. One gender-specific traits once these gender-specific traits are identified, then you can kind of see how these differences are going to shape our counseling strategies. And this is really at the foundation for individualized care that's going to respect the client's lived experience. So there's gender differences with men. Men are more likely to externalize their emotions like anger or aggression. They're less likely to seek out help or talk about their emotional struggles. They have higher rates of substance use and an earlier onset. And they tend to use substances for performance, recreation, or risk-taking. They may struggle with expressing their vulnerability. They're more likely to have legal issues or engage in risky behaviors. There's more peer pressure, and masculine identity often reinforces that use, and they're more likely to enter treatment through the criminal justice system. But with women, they're more likely to internalize their emotions, like having anxiety, depression, or shame. And they often use substances to cope with past traumas or stress or their relationships. They have higher rates of co-occurring mental health disorders like PTSD and anxiety and depression and so forth. They're more likely to experience stigma for using substances, and they frequently serve as caregivers, which can be a treatment barrier. They're more likely to have histories of abuse, both sexual, physical, and emotional, and they often enter treatment through healthcare or social services. And they have a faster progression from use to dependence. We call this the telescoping effect. So the treatment needs for men are going to be different. We're going to need to address denial and help seeking barriers. Then we're going to have to encourage emotional literacy and vulnerability and channel that need for control or mastery into recovery tasks and address any risk-taking and sensation-seeking behaviors. And the ways that we can do this are to provide a structured, goal-oriented program, put them in group therapy that's going to provide them with accountability and a little bit of competition. Trauma-informed care, especially for veterans or those with legal traumas, and then cognitive behavioral therapy to address any distorted thinking patterns they may have. For relapse prevention, we want to focus on stress management and anger regulation techniques, building healthy peer connections, working on identity outside of that traditional masculinity, and encourage any ongoing accountability structures. For women, it's going to be different. Their treatment needs are going to be trauma-informed, gender-responsive treatments. We want to put an emphasis on safety, trust, and empowerment, and give them support for parenting and childcare during their treatment, and focus on self-worth and boundary setting. The ways that we can do this are to provide an integrated mental health and substance use treatment program, give them individual counseling alongside the group therapy, and put them in women-only groups to increase their openness and safety. When I see this, I think about how women will always choose the bear. And if you're not familiar with that, the question posed to women on social media was, if you were walking alone in the woods and you came across the one road had a man and the other road had a bear, which road would you go down? And most women will choose the bear. Holistic approaches, we want to teach mindfulness and use expressive therapies for women. Relapse prevention, we're going to be doing ongoing trauma work and emotional regulation. We want to strengthen their support networks, their friends, family, peer mentors. We also want to address any shame or guilt or relationship triggers they may have and plan for those stressors that are related to caregiving or relationships. There's a couple of biological differences here. Women may experience stronger drug cravings and withdrawal symptoms, and their hormonal cycles can influence mood and relapse risk. And both men and women are going to metabolize substances differently, so that's going to impact dosage and detox. There's some social determinants we have to consider. Men have fewer social consequences for substance use, but more legal ones, while women often face more stigma and they may hide their use longer, which is going to delay their treatment. We also have to consider cultural factors like gender roles and expectations and how they impact people's view on addiction and recovery. We also have to incorporate race and class and sexuality and figure out how they influence, or these things influence gendered experiences in treatment. So we know that women often begin using substances in response to different triggers than men, and their use is more likely to be rooted in interpersonal relationships and trauma and like coping with psychological pain. So understanding these life contexts, like the biological, the psychological, and the social, That's going to be essential in developing appropriate treatment plans, because too often programs use male-centered models that don't fully address the relational and the emotional realities that women face. So a holistic view of women's substance use has to explore like how factors like intimate partner dynamics and societal expectations and caregiving responsibilities are going to play a role in both addiction and recovery. Biologically, women are experiencing the effects of substance use differently than men. So they're often going to develop substance use disorders faster and at lower levels of use. And these are due to like differences in metabolism and body composition. And women are also going to face unique like health risks, like gynecological complications or disrupted menstrual cycles, and like risks to their pregnancy or fetal development. So understanding these differences is going to be crucial for safe and effective treatment. So like, for example, dosage, detox protocols, medication-assisted treatment plans, they all need to be adjusted. Also, clinicians have to be prepared to discuss reproductive health and family planning as part of the recovery process. So while men and women are fundamentally similar in psychological traits, there are some notable tendencies that can affect treatment. So for instance, women may internalize failure more, and they may have lower self-appraisal, and they also may prioritize relationships over their personal goals. And these traits can impact relapse risk, and it's also going to impact our therapeutic alliance with them. So we have to be aware that women are going to struggle more with guilt and shame and that self-worth in their recovery. And that's going to mean that our therapeutic techniques have to emphasize empowerment and validation. And we also need to like start building a strong sense of identity beyond the addiction. So group work really fosters a connection and it reduces that isolation, and that's particularly effective with women. The social realities for women in addiction are often more dangerous and more complex. There's a staggering number of women in treatment that have experienced sexual abuse or domestic violence. And a lot of these women were introduced to the drugs by their male partners or other family members. So they are often going to remain entangled in relationships that are fueling their addiction. And these dynamics call for like trauma-informed care. The treatment has to create a safe space for disclosure. Women have to be able to feel safe enough to address that interpersonal power imbalance. And that's going to help us to empower women to break the cycles of dependency. So we need to educate around boundaries and consent and relationship patterns. And we need to weave that into our individual and our group sessions. Women who are involved in sex work are going to face particularly high risks. A lot of women are coerced into both drug use and sex work, and they're going to experience violence and they're going to experience exploitation. They're also going to face a higher likelihood of contracting STDs or HIV due to unsafe practices. They have a lack of health care. There's so many systemic boundaries and barriers out there preventing them from getting treatment or testing and things of that nature. So as treatment providers, we have to approach these clients without judgment. The goal is just to meet them where they're at, acknowledging, that these survival behaviors are complex. And so we have to provide wraparound support that's going to include like housing and legal aid and healthcare and all types of stuff. Harm reduction, risk reduction counseling, they're all essential components of treatment for this particular type of population. IV drug users, the IV drug use among female sex workers is going to add this just another layer of vulnerability. These women are going to use drugs to cope with the trauma or just to maintain their ability to work. And this is going to perpetuate a cycle of dependency. So without access to safe spaces and supportive treatment, many are at constant risk of overdose and infection and just continued violence. So we want to introduce a harm reduction approach. This is going to be key for this population. So the interventions that we need to introduce here should be needle exchange programs, education for safe sex, education for injection practices, just a non-judgmental access to healthcare and mental health services. So a comprehensive plan should consider exit strategies for like sex work if that's desired by the client. So we know women often use substances in more private and hidden ways than men, which makes identification and intervention harder. There's social stigma, the fear of losing their children, the lack of partner support. These are all common barriers. And these factors make women less likely to seek help and more likely to drop out of treatment early. So we have to understand and validate those fears. Our services should be designed to reduce that shame and protect their parental rights when we can, and just ensure that the treatment environment is welcoming and respectful. We need flexible scheduling, childcare, maybe transportation assistance. Those make a big difference in these populations. We know that domestic violence is tragically common among women in treatment, and it has to be approached with care. The substance use can serve as both a coping mechanism and a trigger for further abuse. So abstinence can even increase the risk of violence because of the shifting power dynamics in the relationship. So when we're working with clients that are impacted by domestic violence, safety needs to come first. So as clinicians, our role here is to assess for any current risks and then collaborate with domestic violence advocates to help the client. And together we can develop individualized safety plans for the client. Any counseling we do here should address the trauma's impact on their health, their emotions, and any relapse vulnerabilities they may have. Thinking about sexual trauma, this deeply affects a woman's self-perception and their ability to trust. So for a lot of the women in treatment, this trauma happened during childhood and it remains unprocessed. So the counseling relationship has to be built carefully with attention to like timing and consent and also the client's emotional safety. We never want to rush into trauma work. We want to build rapport first. And then when the time is right, then we can use empathy and validation and very careful pacing so we can explore that client's experiences. Oftentimes, just simply listening without judgment is more healing than offering solutions. That therapeutic presence itself becomes the corrective experience. And we know that women who use drugs and engage in sex work need individualized treatment plans that reflect their unique realities. Considerations are going to be like the client's safety, the choice of their counselor, especially regarding the gender of the counselor. Also, like access to non-stigmatizing wraparound services. So these, non-stigmatizing, I've heard some horror stories about people saying their counselors were super judgmental. But our programs should include private intake areas. That's going to be important. Nobody wants to tell their personal business out in the middle of the floor. We need to have trauma-informed counselors and have other connections to like healthcare, housing, legal aid, possibly if your program that you work for or that you have could provide case management services, because this population faces the intersecting stigmas of like poverty, addiction, and sexuality. And all three of those in and of themselves are stigmatizing. Point all three of them together, and now it's just extremely shameful. And the treatment environment has to reflect a commitment to dignity and choice and empowerment. So, effective treatment for women is going to involve far more than just abstinence. Um, it's going to start with personalized assessments and a treatment plan that addresses their mental health, any past trauma, and any practical needs that they're going to have, like housing and parenting and whatever. So this is going to require clinicians who are trained in gender responsive and culturally competent care. One thing that's a challenge here is retention. Women often leave treatment because they have unmet needs or childcare barriers, or just the program environment feels unsafe for them. So the programs have to prioritize client engagement and offer trauma-informed care, and we want to document outcomes to adapt services over time. And when we do this well, the approach is going to improve both individual and family outcomes. Wraparound services are really critical in helping women sustain their recovery. These services go beyond the therapy. They address the practical needs that, if we don't meet them, become obstacles to their sobriety. So this is going to include childcare, job training, legal aid, access to safe housing. There's all types of other things, but all of this becomes part of the holistic approach, the 360 approach, heal the whole person. Recovery doesn't just happen in a vacuum. A lot of women return to environments that are chaotic and unsafe and unsupportive because they left their treatment program. So by coordinating these services that are going to stabilize their lives, we're going to increase their ability to focus on their healing and really build a new future for that woman and their families. Treatment works, but only when it's designed with the women in mind that we're treating. Women have very unique pathways into addiction, and their recovery journeys have to honor their history and their strengths and their vulnerabilities. So, trauma informed, relationship centered care is not optional, it's essential. And when we integrate these wraparound services, it's going to offer safety and support, and just understanding the barriers that women face. That way we can deliver care that's going to be empowering for that client and also life-changing. We need to move away from that one-size-fits-all approach and toward a system of care that recognizes women as whole people, worthy of dignity and healing and hope.